Hello, welcome to the EKG Guy and welcome to the EKG of the week. I hope you're having a great week and I'm glad you could join us. So this week's case is a 30-year-old male with a history of drug-induced ischemic cardiomyopathy with an ejection fraction of 10 to 15%. His recent EKG is shown below. Before we get started, let's review the approach we've been using to interpret EKGs. So notice that we have the patient's clinical presentation and then the EKG below. On the right side of the screen, we have a list that we'll go through before making our final interpretation. First, there is the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? And then if it's irregular, is it regularly irregular or irregularly irregular? Next, we'll look at the heart rate, in which we simply want to determine what the rate of the rhythm is. Then we have the rhythm origin, that is, where's the rhythm actually starting from within the heart. Then we have to find the ventricular or QRS axis, which could help us with our differential diagnosis. Then there's the atrial, atrioventricular, and intraventricular conduction, looking at if conduction is normal or abnormal. Then we have the waveforms, which would include all the waves, segments, and intervals, and lastly, anything else, meaning is there anything else that we've missed or still need to mention? After that, we'll use all this information that we gathered and make a final interpretation of the EKG. Now I want you to pause the video and take a few minutes to go through it yourself. When you're ready, start the video and we'll go over it together. Okay, so our 30-year-old male with a history of drug-induced ischemic cardiomyopathy and ejection fraction of 10 to 15% has this EKG. So let's go through it now. So first, what is the regularity of this rhythm? Well, on first impression of the EKG, you probably notice that the rhythm appears quite regular. In fact, this is a regular rhythm. Okay, so how do we know that? Well, one simple way is by looking at the intervals between our R to R waves, okay? So if we point out one R wave to the next, we call this our R to R intervals, okay? And a regular rhythm will have these constant R to R intervals throughout, okay? And if you look through these, you'll see that this first R to R interval is similar to the next R to R interval, okay? And if you continue to look at all these by using your calipers, you'd see that these R to R intervals are consistent throughout the EKG, okay? So because of that, we call this a regular rhythm, okay? So the regularity is regular in this case. So what did you get for the heart rate? Well, there's a couple ways we can do this because we're dealing with this regular rhythm. So one way is by knowing that the width or the duration of this EKG represents 10 seconds, meaning from the beginning all the way up until the end, this is 10 seconds. So if you multiply 10 seconds by 6, that gives you 60 seconds, which is 1 minute. Meaning that if we count the complexes going across, multiply that by 6, that can give us an estimate of the rate in beats per minute. So let's try that, okay? So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, okay? So we counted 15 complexes going across, so what we would do is 15 times 6 is 90 beats per minute, okay? So that's one way you can do it. And this is the ventricular rate because notice we counted the QRS complexes. Another way we could do this because we have a regular rhythm is to find a QRS complex that falls on one of the thick lines and then find the next R wave in this case and count the number of thick lines between it. Okay, so let's erase some of this here to make it clear for you. Okay, so what we want to do is find a complex falling on a thick line. In this case, we can use this one here. Notice it's on this thick line. Now we're going to find the next R wave, which is this one here. We're going to count the number of thick lines between it. So notice there's 1, 2, 3, okay, and just over 3. So what we would do is 100 divided by 3 is 300, excuse me, divided by 3 is 100 beats per minute, okay? And in this case, it's a little more than 3 thick lines, so it should be less than 100 beats per minute, okay? Now the actual rate in this case that the machine got was 89 beats per minute, okay? So close to what we got here at 90, okay? So that's our rate. Now we have to look at the rhythm origin. Well, we have narrow QRS complexes, so it must be supraventricular in origin, that is originating from above the ventricles. We can also make out clear, defined, similar shaped P waves in each lead. So we have to check if we're dealing with sinus rhythm. So let's see if we have that. So one of the main things we want to look for is the upright P waves, okay? And upright P waves, we want to see them in leads 1, 2, AVF, V4 through V6, okay? And why do we want upright P waves? Well, imagine that you have your right atrium. So let's draw our heart here, okay? Here's our right atrium. This is our left atrium, right ventricle, left ventricle. So normal sinus rhythm means that it's going to start from our sinus node. So imagine our sinus node up here, and our right atrium near our superior vena cava comes down with our internodal pathways to our AV node. There's a Bachman bundle coming to the left side. Then we have our His bundle that splits into the bundle branches, the right bundle branch, and the left bundle branch that has an anterior and posterior fascicle. Okay, now with sinus rhythm, all we want to see here is focus. We want the origin to be coming from this sinus node here. Okay. And because of that, the direction of the impulse will be heading in this direction. Okay, so if you imagine the right atrium sitting on this, okay, our sinus node right here, our normal impulse should be heading in this direction. In fact, the normal P wave axis is between 0 degrees and positive 75 degrees, okay, so in this direction here. Now the leads that the impulse is heading towards will see upright positive P waves. So lead 1 sits here, okay, AVF is here. We have lead 2 sitting at positive 60 degrees. V4, V5, and V6 are in the horizontal plane. So we typically see upright P waves because it's hitting leftward and inferiorly, and then lead AVR is here, so we'll see inverted or negatively deflected P waves. So let's take a look at our EKG here. So here's lead 1, okay? So lead 1, you can see these upright P waves there, okay? Here's lead 2, these upright P waves, all right? AVF, we can also see some upright P waves there. And then if we look at these left lateral precordial leads, here's a P waves, okay, in these, all right? And notice that they have the same morphology within each lead. Now in AVR, which is this one here, we said we would see these inverted P waves, which we certainly do see these here, okay? So we are in fact dealing with sinus rhythm. Now a few other things you want to make sure of is the morphology, which we said was the same, as well as that there's a P wave coming before each QRS complex, meaning you have this P wave. So if you look here in V1, this is a P wave and a QRS complex. P wave and the QRS complex. So the P wave's coming before, preceding the QRS complex in each of these beats, okay? And there's one P wave for every QRS complex, all right? So because we meet all that criteria, we are in fact dealing with sinus rhythm. So our origin of this rhythm is from the sinus node. Now let's look at the ventricular or QRS axis. And you should have gotten a leftward axis or left axis deviation. The actual axis here is negative 63 degrees. Okay, so how do we find the axis? Now, what we want to do is look at a few key leads. So I'm going to erase this here because we're going to have to look at this in a second, all right? So the leads I want you to focus on. So first, let's look at our quadrant system. This is 0 degrees, where the positive end of lead 1 sits. This is positive 90 degrees, where the positive end of AVF is, okay? And then we have plus or minus 180 degrees and negative 90 degrees, okay? And now normal axis lies in this quadrant, okay? Leftward axis here. This would be a rightward axis, okay? And then this is considered extreme axis deviation if it were in that quadrant. Normal axis is actually defined from negative 30 degrees to about positive 105 or positive 110 degrees. So all this region here is normal ventricular axis, okay? And what we want to do is look at leads 1 and AVF first. So if we look here at 1, notice that we have an upright positive QRS complex, so we're heading towards lead 1, okay, the positive end of it. If we look at lead AVF, we can see negative complex. So we're heading away from the positive end of AVF up here, okay? This is the positive end of AVF. We're going away from it. So our axis lies somewhere in this region, okay? Now we have to figure out if we're within this normal axis region here or if we're in this leftward axis region in this case, all right? Now we have to look at another lead to determine that. The other lead here comes to about, in this case, positive 60 degrees, and that's lead 2. okay? So lead 2 is in that case, and if you look perpendicular to lead 2, it actually runs along here, along that negative 30 degrees, meaning that if it's positive, it's going to be on this side in that normal range. If it's negative, it'll be on this side of the line in our pathological leftward axis shift, okay? So let's take a look at lead 2. Lead 2 is negative, okay? Meaning that the axis lies in this region here, all right? Remember, we said the actual axis here was negative 63 degrees. So that's in that pathological leftward shift in our axis. So what we have here is leftward axis deviation. The axis here is negative 63 degrees, okay? And hopefully that makes sense how we were able to find that, okay? So how about atrial conduction? Well, typically we're going to look at leads 2 and V1 for P wave or atrial abnormalities as they appear to be most evident in those leads. Well, in leads 2 and V1, we don't quite reach the P wave amplitude for right atrial enlargement. However, we do have evidence of left atrial enlargement. If you look at lead V1, we can see that the terminal negative deflection of the biphasic P waves have a depth and width of at least 1 millimeter. In addition, the total duration of the P waves in lead 2 appear to be beyond 110 milliseconds, which is considered the upper limit of normal, okay? So let's take a look at this leftward axis or left atrial enlargement. So remember, we're going to look at leads 2 and leads V1, okay? And one thing that you should be aware of when we look at P waves, so imagine this is a P wave in lead 2, okay? And let's look at 1 and V1. So we'd have something like this. The beginning portion of our P wave represents right atrium, or the right atrium depolarizing, okay? And the terminal portion represents the left atrium depolarizing, okay? So notice this upward, this positive deflection in lead V1 represents the right atrium, and this terminal portion represents the left atrium, okay? And that should make sense because remember, our sinus node is in our right atrium, so the beginning portion of the P wave represents right atrial depolarization, okay? And then the left atrium depolarizes afterwards, okay? So when we look for right atrial enlargement or problems on the right with the right atrium, we're going to look for in the beginning portion of the P wave, okay? And we tend to see an increase in the amplitude. When we look at for left atrial enlargement, we're looking at the terminal portion of our P wave, okay? In lead 2, you may see an increase in duration and something called P mitrale, where you can have this notching of the P wave, or these M-shaped P waves. And then in V1, we're going to look at the terminal portion of the P wave, okay? And what we want to see is a width of at least 1 millimeter and a depth of at least 1 millimeter, okay? So if you look here, we can see, and it's hard to see it here, but if you trust me, you can see that the P wave duration in this case, so the width of it, is actually greater than 110 milliseconds, so beyond that upper range of normal, okay? And remember, we said things that prolong the P wave have to do with the left atrium, okay? And if you look at V1, you can see, notice this is the positive deflection representing the right atrium, and this portion here is the left atrium. Okay, and we in fact can notice that the left atrium is enlarged because it's at least 1 millimeter wide and 1 millimeter deep. Okay, so in terms of atrial conduction, we do have prolonged conduction, okay, because of enlargement of the left atrium. Okay, so left atrial enlargement. Okay, and we can see that evidence by that terminal biphasic P wave that's greater than 1 millimeter wide and 1 millimeter deep, okay, as well as the P wave in lead 2 that has a duration of greater than 110 milliseconds. Okay, now how about atrioventricular or AV conduction? Well, in this case, we're looking for any conduction delays as the impulse travels between the atria and the ventricles. Because the majority of the PR interval represents AV nodal conduction, we're going to look there. The normal PR interval in adults is between 120 and 200 milliseconds, or 3 to 5 of the small boxes. Here, the PR interval is within normal limits. It's actually measured on the EKG machine as 188 milliseconds. Okay, so we do have normal AV nodal conduction. The PR interval was 188 milliseconds, so below that 200 milliseconds or upper limit of normal. So next we have intraventricular or IV conduction. Here we look at the duration of the QRS complexes. Normal QRS duration is often between 70 and 110 milliseconds, or about 2 to 3 small boxes. The main thing we're checking for here with intraventricular conduction is whether or not the QRS interval is prolonged. We can see narrow QRS complexes that appear within normal limits, okay? The actual QRS duration here was 106 milliseconds. So that helps confirm that the intraventricular conduction is normal, okay? So we have normal IV conduction, and it was 106 milliseconds, which is less than that upper range of 110 milliseconds. So how about the waveforms? Well, we said the P waves were abnormal with evidence of left atrial enlargement. We also will notice here that we have pathological Q waves, okay? If you look at leads V1 through V4, you can see these wide and deep Q waves. Now, pathological Q waves in leads V2 and V3 are defined as Q waves that are at least 20 milliseconds wide, or the presence of QS complexes. In all the other leads, pathological Q waves are defined as Q waves that are at least 30 milliseconds wide and 1 millimeter deep, or the presence of QS complexes. We can certainly see evidence of abnormal Q waves in leads V1 through V4, and this suggests evidence of an anteroseptal infarction. And remember, the EKG is a dynamic during the infarction process, or ischemia, okay? And pathological Q waves tend to occur about 6 to 16 hours following the onset of ischemic symptoms. So if you look here, okay, we're saying that in, let's just erase this here, we're saying in leads V1, V2, V3, and V4, okay, so not these leads, so I'll erase them, we can see evidence of these abnormal Q waves, okay, and these are these ones here, okay. So these deep Q waves, very deep here, okay, and that is evidence that we're suggesting of an anteroseptal MI, okay, likely one that's already occurred. So remember, the V1 and V2, we tend to think of them as the septal leads, as in then from V3 and V4, more of the anterior leads, okay, over the anterior portion of the left ventricle, okay. So because we have these abnormal Q waves in V1 through V4, we're thinking of a prior anteroseptal MI. Now, in terms of the T waves in leads V1 through V4, they appear as post-ischemic T waves. Normally, the T waves are asymmetric with a steeper downslope, which we do see here. However, in leads V1 through V4, the T waves are discordant. Normally, T waves are concordant with the QRS complexes, and this discordance suggests post-ischemic T waves, okay? So if you look here, we'll erase this so you can see it. Okay, so notice that the QRS complexes in V1 through V4 are mostly negative, okay, going downwards. Okay, you can see these here. Same thing in V4. And then if we look at our T waves, okay, especially in leads V2, notice that our T wave is positive going in the opposite direction. V3 and V4 are the same thing, okay? So because the main QRS vector or axis is going in the opposite direction of the T wave, we call this discordant, okay? And this is something that's abnormal. We can see it in bundle branch blocks or post-ischemic T waves is what we're seeing in this case here. So because of that discordance of the T waves to our QRS complexes, these we tend to consider as post-ischemic T waves, okay? So hopefully that makes sense. All right, remember that we want normal T waves to be asymmetric, have a steeper downslope, and we also want them to have this concordance with our QRS complexes, okay? Now, the PR segment is not significantly depressed or elevated. The PR and QRS intervals we said were within normal limits, okay? The QRS amplitude also appears within normal limits. The ST segment does not appear significantly elevated or depressed anywhere. Now, it may appear that there is slight ST elevation in leads V2 through V4, although this is not significant. First off, our patient is the male. He's under 40 years of age, right? He's 30, okay? Therefore, pathological ST elevation is when the ST elevation is greater than or equal to 2.5 millimeters in leads V2 or V3, or when it is greater than 1 millimeter in the other leads. This is not the case here, so there's no significant ST elevation. Okay, so what we're seeing here is in V2, okay, it may appear that here's V3. Notice that it looks like there might be some ST elevation in this case. Same thing here, maybe slightly in V4. okay, and in V2, but it actually doesn't reach that upper limit. So in V2 and V3, we want it to be 2.5 millimeters, which it's not here. And then the other lead, so V4, should be at least 1 millimeter, okay, and it's not in this case. So there's not any significant ST elevation in these leads. And lastly, with the waveforms, the QTC interval is prolonged. The normal QTC interval in males should be less than 440 milliseconds. Here, the QTC interval was recorded as 508 milliseconds. So that's prolonged. So we'll write this here. So prolonged QTC, and it was 508 milliseconds. Okay, so beyond that 440 milliseconds that we considered the upper limit for males. All right, so is there anything else we're missing here? Well, how about the R wave progression in the precordial leads? Normally, the R wave amplitude should progressively increase from leads V1 through V5, and we certainly do not see that here, which may further support our suspicion of an anterior septal infarct. Okay, so if you look here, normally our waves should increase in amplitude as we go from V1 through V5. So here's V1, V2, V3, and up until V5, we should see an increase in our R wave amplitude. Notice that we don't really see one in these leads. Okay, so it should normally keep getting larger and larger as we go throughout these, but we don't really see that. Okay, so because of that, we call this poor R wave progression. Okay, and that can be evidence of an anterior MI. Now, the transitional zone is something else that we have to look at. Now, in the precordial leads, in this case, it appears to be between V4 and V5. And what we mean about the transitional zone is that it's the precordial lead where the QRS transitions from being mostly negative to mostly positive, with the actual transition area to be where the QRS complex is isoelectric. Normally, the transition occurs between leads V3 and V4. Okay, and if it occurs earlier than V3, then this is called a counterclockwise rotation or early transition. And if it occurs after lead V4, then we call this a clockwise rotation or late transition. Therefore, because the transition occurs after lead V4, we call this a clockwise rotation or late transition. Okay, and this clockwise rotation is also supporting evidence of an anterior infarct. Okay, so notice here, we'll just erase this so you can see. So normally we want to go from mostly negative to mostly positive between V3 and V4. So notice it's negative, negative, negative. We should see the transition here, but it's still negative and doesn't become positive until V5, okay? Meaning the transition occurs somewhere between here. Now, because it occurs after V4, we call this a clockwise rotation, okay? Or late transition. Okay, and this is not normal and may be evidence suggesting an anterior infarct. Now, one thing to keep in mind with R wave progression in transitional zone is that they're highly dependent on lead placement. Now, there's one last thing we need to mention here. We saw that we have a leftward shift in our ventricular axis beyond negative 30 degrees, which is considered pathological. In addition, we can see QR complexes in leads V1 and leads 1 in AVL, along with RS complexes in the inferior leads 2, 3, and AVF. All of these findings suggest left anterior fascicular block. Okay, so let's look at this here. Okay, so erase what we're saying. So what we said earlier is that we have leftward axis deviation, okay, at negative 63 degrees. So this is pathological, okay? And so what we saw was this positive upright complexes in lead 1, okay? In lead 2, we see these negative complexes. And then in lead AVF, we also see these negative complexes, okay? So another thing to note with this left anterior fascicular block is that we see these QR complexes in leads 1 and AVL. Okay, so here's lead 1. Notice that we have these small Q waves here and then these R waves. Okay, so we call this a QR complex. And the same thing with AVL. We have a small Q and a big R wave. So that's a QR complexes. And then in leads, the inferior leads, we see RS complexes. Okay, so the inferior leads would be 2, 3, and AVF. Okay, and you can see these small R waves in these deep S waves. Okay, we call these RS complexes. Okay, so having this leftward axis deviation, the QR complexes in leads 1 and AVL, and these RS complexes in 2, 3, and AVF, this suggests left anterior fascicular block. Okay, so we'll add that here, left anterior fascicular block. Okay, so it's important to be aware that left anterior fascicular block can mimic an anteroseptal MI, which we believe is present here. And clinically speaking, left anterior fascicular blocks are more common than left posterior fascicular blocks due to the left anterior fascicle's smaller arterial supply and its thin bundle of fibers. In addition, isolated left anterior fascicular block is considered benign, although in some cases it may progress to bifascicular block with involvement of the right bundle branch, or even complete AV block. Anyway, so what's our final interpretation? Well, we have a regular rhythm with sinus origin and a rate of 89 beats per minute. The ventricular axis is shifted leftward to -63 degrees. There is evidence of left atrial enlargement. There is normal AV and IV conduction. There are pathological Q waves we saw in leads V1 through V4, poor R wave progression in the precordial leads, and a clockwise or late transition, okay, in the horizontal plane, all of which suggest an anterior left ventricular damage, okay, or infarct. We also notice a prolonged QTc interval and evidence of left anterior fascicular block. So all of these are likely the result of the patient's ischemic cardiomyopathy. And of note, when compared to a previous EKG, there were no significant changes. Okay, so let's just write our final findings. So I'll erase this here. Okay. So one of the main things, so notice that we have normal sinus rhythms because we have a sinus origin and a normal rate and regular rhythm. So normal sinus rhythm. Okay. We also mentioned the left atrial enlargement. We mentioned left anterior fascicular block. Okay. There's that prior anteroseptal infarct or MI. Okay. And then we also mentioned the prolonged Qtc interval, okay? And if we looked at the previous EKG, okay, so on the prior EKG, there were no significant changes, okay? So no significant changes on our previous EKG, and you always want to make sure and look back if anything new has occurred. So in conclusion, our 30-year-old male with a history of drug-induced ischemic cardiomyopathy with an ejection fraction of 10 to 15% has an EKG showing normal sinus rhythm, left atrial enlargement, left anterior fascicular block, prior anteroseptal infarct, and a prolonged QTc interval. Well, that's the end of this week's EKG of the week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you can help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos. There's also a community of over 150,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guy's Facebook community. If you need a crash course on EKGs, we launched our new EKG course. Check the link below if you're interested. The original cost is around $150, and I believe I made it less than $20 for a limited time. I may be biased, but after reading nearly every EKG textbook on the market, I think this is by far the best EKG series to take you from the beginner level to a physician level. I've even included our pediatric lectures. Anyways, check it out for yourself. I think you'll really enjoy it, and a number of medical schools and hospitals are beginning to use it. If you are a part of an institution, please contact us because we're giving a limited number of schools and hospitals free access to provide feedback and improve our course. And in that case, you can get the course for free. So leave a comment below and get in touch with us. And of course, check out our brand new website, ekg.md, the premier EKG resource for medical professionals, where you can find more lessons and practice. That is www.ekg.md. Last but certainly not least, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. So let us know how we're doing. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.